Ladies and gentlemen, welcome to the MedTech Impact Podcast, where you get to hear from leaders and innovators who are shaping the future of medical technology. I'm Kyle Cruz.
And I'm Richard Meiklejohn.
And we're your hosts of the show.
So today on the MedTech Impact Podcast, we are delighted to be joined by Jeff DiLullo, CEO of Philips North America. Jeff, welcome to the show.
Well, thanks for having me, gentlemen.
It's an absolute pleasure, Jeff. I mean, I think in terms of excitement levels, this is about as high as it gets for us. You know, we're so excited to have you on the show and clearly to tell all the amazing work that Philips is doing. So before we get into that, I think it's probably well to set the scene for the listeners, because I think for anyone who is familiar with Philips goods, you maybe have a Philips toothbrush in your bathroom, you maybe have a Philips lamp by your bedroom, but clearly Philips does a lot more than that. So for anyone who's unfamiliar with Philips, maybe you could just tell us a little bit more about the company today and its main mission.
Sure, that'd be great. And it has changed over the years. So Philips is a pure health tech concern. We have a rich history in innovation and technology, but today we're about 70,000 people globally. We have a footprint of 17,000 Americans employed by Philips, with the largest operating division within the company. Our headquarters is in Cambridge, Massachusetts. It's also our innovation headquarters for the company. And more specifically, our mission is what drives every single thing we do. We became a pure health tech concern about 13 years ago, and everything we do now is about improving health and well-being of 2.5 billion lives this decade. And we explicitly call out on our mission 400 million in underserved communities. So that is our driver.
That's a strong calling card. And for you personally, I think you've now been with the company about 5.5 years.
Yeah, I came here because of the mission and the passion to serve something bigger than myself and serve, really, we believe healthcare is a human right. And so everything we do and we construct is about bridging the access to care gaps everywhere we possibly can to give everyone the same access to care that they deserve.
Well, Kyle, this is music to our ears, because clearly this is what the MedTech Impact Podcast is all about. Having missions like this and having people like Jeff who are looking to address and drive forward these missions.
Yeah, completely agree with you, Richard. And I mean, it's really inspiring too to hear, about the mission Philips is on. And Jeff, I'm inspired, from a recent report, the Future Health Index that recently came out with nearly 3,000 healthcare leaders across 14 countries contributing to the report. It's pretty impressive stuff. I mean, obviously Philips is really dead set on trying to help patients around the world get access to care, but obviously there are some clear challenges that's getting in the way. And, we're hoping that you may be able to talk a little bit more about those challenges and what you guys produced in the Future Health Index report.
Yeah, thanks, Kyle. And so I'll set the stage very quickly. We do this. This is our 9th survey. And this is, like you said, broadly, it's a universal survey across health providers, from health providers, for health providers, to show what we think is truly universal trends. Some challenges we typically uncover. This year, we focused on the need for innovation and solutions to help staffing challenges and access issues. And so we called it, the theme of this year is better care for more people. And so some of the challenges that that the health providers surfaced in this survey, 3 quick stats. Number one, 9 out of 10 said that their ability to deliver better healthcare is being inhibited by extreme stress, burnout, and mental wellness issues as a result of the staffing challenge that they've had. That's 9 out of 10. Now, I will note in the United States, it was significantly higher, twice that of the rest of the world. So we ought to unpack that a little bit more as we go deeper into the findings, but clearly an issue here that we have to address. It's almost existential for the profession. The second thing, 8 out of 10 said that they believe, because of those staff shortages and stresses, that delays in care, the standard of care, things like increased wait times for appointments, decreased time spent with patients, are a continuing trend and they see getting worse. That's 8 out of 10. And then the third big stat for us is that 9 out of 10, or roughly 88% of those respondents, said they see automation and AI as a way to gain back the initiative and improve the quality of care delivery.
Those are incredible stats and certainly eye-opening. There's no doubt about that. I can tell you right now that I just recently got a new doctor, and I went to schedule that appointment. and it was, hey, see you in 5 months,
Yeah.
and you're like,
Yeah.
ah, interesting. Now I'm fortunate, right, where I'm in okay health, right? I can wait. But that is just staggering, even down to changing my dermatologist,
Yeah.
see you in 4 months there. So, I mean, this is real. And I think it's incredibly relatable to everyone listening today. I'm sure they've experienced something similar. So,
Think about this,
yeah,
Kyle.
yeah.
Because I love your point. Like you can wait, but what if you have a condition that you didn't know about, that appointment that only took you a month to get instead of 5 months meant the difference between a terminal diagnosis and a life-saving surgery. That time isn't even about your health and the ability to get well faster. It could be diagnosing something you don't even know about yet.
Mm.
That that's the access to care gap that we're trying to solve with shortening those wait times, improving productivity for staff, and by doing that, giving them a little better health and well-being. But go on. But I think it's really poignant because it calls out the issue we're seeing, was the unsaid killer of time.
Yeah. Well, what do you think it is, Jeff? Like what kind of led us to where we are today? What caused these challenges in the first place to burnout? Do you have any insights on that?
Well, I think you could clearly point the biggest one, and we've seen this across many industries, but in healthcare specifically, the pandemic was an inflection point for people in their careers, their livelihood. A lot of people left the profession after the burnout they experienced. There's a flywheel effect on that because when people leave, there's smaller staff, and people aren't coming into the profession as fast as they're leaving. So those that are here are more burnt out and more stress, and then they leave, and so it's a sort of a self-fulfilling prophecy that you create this problem almost at an exponential rate in the last 4 years.
Yeah. Well, it doesn't help when clinicians, have those just brutally, just real challenging experiences. And then when they leave that profession, obviously they're telling everyone just how brutal and miserable they were. Right. So now it's like, oh, well, no one wants to do that. And it's just crazy. I just saw a young man who was recently hired by another leading med tech company, and he just completed his master's in biology, and he was looking forward to going to med school. And I'm not kidding you when he told me, the reason why I didn't do the med school and spend all the money and spend all those extra years is because I didn't want to go into a profession right now that is so grueling and intense and is just going to, really impact the quality of my life. So, but he
Yeah.
was still inspired to, help people. So he decided to go work for the manufacturer, on the clinician sales side.
Yeah.
And and that's tough because this kid was absolutely remarkable. The industry lost a great guy right there. He would have been an amazing clinician. And it's just tough when you hear some of this stuff, And so, Richard, I think that kind of makes me think about, how do we prevent this? How do we prevent this from happening? How do we make it easier for clinicians to do their job so that they want to pursue a career in that area, and then obviously help patients in a more efficient, effective manner?
Absolutely, because I think you quite rightly point out all the problems on the healthcare professional side, but the other side is this increasing demand. So, around the pandemic, a lot of elective surgeries were postponed, and obviously with people aging in society, we know that's increasing healthcare problems. And so naturally, we're looking for solutions. Jeff, what are these opportunities? Where do you see the next big chance to make a difference and tackle some of these challenges?
Yeah, I think, and one other interesting note is if you think about some of the manual activity that's had to happen in the healthcare industry, it's been slow to change. With millennial and Gen Z becoming a larger percentage of the workforce, the ability to deploy technology now becomes a requirement, not an option, right? So you have to be able to capture workers that can do what they. But I think with all great stresses, and clearly the survey suggests that there are significant stressors on the staffing situation, there are also great opportunities. And I am a med tech provider, so I'm obviously coming with the bias that technology solutions are now coming a tipping point, if you will, at scale to be able to deploy broadly as business models to really start to alleviate some of that challenge. I'll sort of tease you a little bit with the ways I see it. I see it in terms of sort of simple to hard as automation. There's a lot of automation that's happening today, from repetitive tasks, automation to reduce manual activity, not just back office, but also now with clinical work. The second area is around virtual care models that are rapidly evolving to be much more about remote patient engagement, leveraging top of licensure for practitioners to be able to extend care. And then the third, obviously, AI, and there's a lot of space in AI. That's kind of like saying, hey, I went to work today. Well, what did you do? There's a lot of different ways to think about that. But in short, AI is a rapid accelerator of diagnostic workflow, all those things. I can talk about that later, but there's three areas we definitely see focus.
Yeah, and three big areas in themselves, and so a huge potential, a huge opportunity, Kyle, to carry forward and again try and address some of these significant challenges being faced.
I mean, I do think right now, obviously hearing about all of these, higher level technologies, I'm really curious too on, what kind of specific technologies within Philips, are helping, drive improvements in these areas.
Yeah, I think so. Assuming I think most people, 99% of the survey response, by the way, said that they saw data-driven insights as a major way, statistically significant, it's unanimous, a major way to improve productivity and optimize staff workflow. But there are things like patient check-in, patient scheduling that are already well on the way to being automated. So if you go into the technical clinical side of this, I'll talk about virtual care for a minute, and then maybe if we have time, we can go to more structured discussion around AI. But in virtual care, the model I'd like to leave with you is it's not just telehealth on the physician's care network, right? PCP network. It's not just that sort of front end dialogue like you're classically thinking of telehealth. It's there. There's some regulatory issues with that. We got to work through some policy, but that's simple. When I think about virtual care, I think about the end to end. How do we leverage technology to move into universes to bring care closer to human beings where they live and work, as opposed to having them come to a hospital? So things like remote patient monitoring, where I can access somebody with an IoT or Internet of Things enabled device to be able to measure their biometrics and their telemetry remotely. So if they have a problem or I see a problem coming, I can call them and say, hey, come in. I'm getting people there, or over the shoulder video consults or collaborations around more complicated cases. So I can actually have physicians anywhere in the world be able to talk real time in a collaboration, just like we're doing today on a case to drive a better diagnosis and a treatment path. A couple examples though, I could talk about a couple examples in a hospital and out of a hospital, if that makes sense for you guys.
Please.
Yeah. The in the hospital example, probably the easiest one. I'm a veteran, and I love that we do so much work with the VA, because that is a perfect ecosystem for us to practice and deploy technology at scale, test it against with an organization collaborating that has the same mission we do. Every single veteran deserves the same level of care. So how do we do that? Well, one of the ways the VA came to us and said, look, we have ICUs that we can't staff, 172 VA medical centers, but half of them are in fairly remote locations where they can't keep the staffing up for ICUs, highest level of care. So we co-collaborated with them and brought a virtual ICU where it's a command center looking over numerous hospitals within their network to be able to scale the highest licensing practicing nurse to be able to have audio, visual, telemetry, and biosensors to be able to monitor that in real time as if they were in the room, and then call a lower level of licensed nurse in to do any physical activities in the room if they needed to for an intervention or alarm. So we made a dramatic impact on the quality of life for those nurses and the quality of the care that we were delivering through a virtual command center type network. The other one, I know that's sort of a long vignette, but the other one here for me is when I think of what we're doing in radiology, right? I had mentioned earlier that we're going to lose 10,000 radiologists in the workforce in the United States in the next decade. Fewer coming in than are leaving. That means you've got to radically improve the throughput of what you're doing in radiology. One way we're doing that with RadNet, for example, is we have what's called a Radiology Operations Command Center. Again, highest licensure radiology technician administering multiple radiology exams locally, close in imaging centers where people live and work. They're not having to drive to hospitals. They're not having to pay as high a cost for that same exam. And so we're able to kind of send the protocols, standardize the protocols, make sure they're done with a high quality way, but also extend that licensure of the best radiology technician, where you have somebody locally dealing with a patient's experience and getting into the room. And the automation on the device itself enables us to kind of administer that remotely. You can increase throughput like we did with RadNet from 15 to 20%, literally almost overnight. That's lower wait times, faster throughput, better access to care, faster diagnostic.
Yeah, well, I think, going back to your first comments around, devices, diagnostic devices, producing, providing feedback to the doctors to be able to provide early detection, probably more personalized medicine and treatments, right? So now that's, hey, let's nip it in the bud now, right? And let's try to prevent you from needing to come back here, in the simplest terms, right? So it's really neat kind of connecting the dots there.
Yeah, and not even just coming back, it's like getting there in the first place. I mean, one of the eye-watering figures, I think, from the report is this huge number of Americans who live in these healthcare deserts. I think it was like 121 million people. You're talking over a third of the population who just don't have access to essential care. And it was so refreshing when we had Jennifer Law, the maternal health leader from Philips, on recently, just talking about some of the initiatives. And I think to your point, Jeff, you are really showing fantastic leadership in bringing solutions to market which can address these significant problems. And so I think this is one, critical, but two, is just really exciting what you are doing in this space.
Yeah, I'm going to go back to the mission, right? So this is my Philips hat on. Our mission is to improve quality of health and well-being for everyone, and specifically close the chasm for underserved populations. So it's in our mission. Therefore, our R&D dollars go there. Our partnerships go there. For example, like I'm sure Jennifer talked about what we're doing with the Bill and Melinda Gates Foundation with about 60 million in funding toward AI, so that I can put an iPad-based OBGYN transducer in the hands of a local practitioner that can do AI on the system to help diagnose and look for abnormalities. But I can also, in real time, video conference in with a higher level obstetrician or collaborative work that can look at the study, communicate with the expectant mother in real time, so they can go through the exam, and they could be hundreds of miles away, right? It's unlimited, and so those are the kind of breakthroughs, particularly with maternal care, where I think we really change the game, especially in underserved communities, which, for example, women of color typically have a 2 to 3 times mortality rate higher in pregnancy and perinatal than white women in similar geographies, just because they don't have the access, and we're bringing the access to the community.
Yeah, and the good thing, again, the beauty of this report, a lot of this solidifies some things we do know, but 99% of leaders believe there are opportunities for data-driven insights to improve care. Not quite sure what happened to the other 1%, but yeah, I think it's clearly, this is the future. This is what's happening. And again, if we're going to go forward and provide care to everyone, and to particularly those who right now are missing out on care that they are deserving and should have access to, then the likes of telemedicine and this integrated care system is the only way we're going to achieve this.
Yeah, and do I dare knock on the door of AI, because that could be a lot of things. But if you think about these virtual models, the one thing I'll say, and hospitals are now at a point where they see the value. Some systems are more aggressively adopting that capability and kind of understanding the cost models to do that. Our job is not just to prevent technology, it's to work with them to see in their system what's the optimal patient flow they're trying to get to. How do we integrate into their systems, their processes, and their workflow, right? So we actually have people that sit and watch workflow in a hospital or in a regional care center, and how they interact between them, so that we're designing the technology to fit the work they're already doing, not trying to make them fit into something as a technology template, right? That's a big way to drive change faster. Let's talk about AI.
Please, let's talk about it, because obviously it's the future. It's being talked about, over and over and over to nauseum. Like, it's insane, right? Everyone's talking AI, but the reality is that, it's instrumental to driving efficiency, right? So tell us, Jeff, how is Philips approaching AI?
Yeah, there's a step function shift, and it's fast, and it actually is accelerating speed. So what I'm going to do is I'm going to take a risk here to be a little containerized here, make it a little concrete in the way that we see it most applicable today. There's a lot of things on generative AI that can help into the future. There's a lot of diagnostic tooling, obviously, that we're working on a lot with other innovation engines and startups to kind of look at how do we really harness it. And I'll say I'm not going to talk as much about that here, because that's the Wild West. But I will say we are strong supporters of the ability to develop those generative AI solutions responsibly. So our Royal Philips CEO, Roy Jacobs, sits on the National Academy of Medicine's Code of Conduct Board for responsible use of AI. We have our own code of conduct in our innovation engines and how we're deploying or developing and deploying AI. So we're also very conscious that there's a lot of concern about it. So, but I'm gonna make it concrete. I'm going to call it the AI stack. I'm a technologist, so I think about the stack. The baseline of the stack is how do we put AI on a system to make it perform better, faster, better patient outcome, better diagnostic. And I'm going to take this through the kind of a radiology workflow, because that's where a big staffing challenge is. So at Nicholas Children's, for example, we're deploying in Florida, we're deploying to the most vulnerable population, small children that are having scary events and they have to get an MRI. You've been in an MRI, big clanky magnet for 45 minutes, right? It's a scary thing for the toughest of us. If I can shrink that time by 2/3 and I can make it a 15-minute exam, I can avoid sedation. I can put technologies around like watching a Disney movie right in the lens through a mirror. I can have them watch a movie. They can have earphones on. And I can make it a pleasing and calming experience so that they're alert, not sedated, and I get them in and out quickly. Fewer rescans, better patient experience. That's on the box. That's technology that exists today, not to fill in the blanks, but to remove clutter and create clarity. It's already out there, and we're doing thousands of scans a day like that in a fraction of the time. The next layer is kind of the, what do I do with it? I have workflow, right? I have radiologists that can't afford or don't want to come to the office at 12 o'clock at night to do a reading, but they have a priority reading from an emergency department. Okay, well, let me just log in at my computer at my bedside and let me do what I need to do. And by the way, let me bring somebody else in. That exists today. That is all AI driven because I can prioritize based on what I see in the image. I can prioritize the routing of that. And then the third piece, which is probably more nascent, but happening, I think, to the point where it's almost at scale now, is findings and incidentals even, and things that I would narrow in on the intelligence on a scan so that I can bring it to the radiologist's attention. So he's always in control of the decision of the diagnosis, but I'm actually giving him insight where to go look. So he's not going through 120 slices, he's going through 6 or 8. That's much faster diagnosis. It's better throughput. I get more people through, and I don't wait 5 months like you did, Kyle, for your appointment, right? You get in, get out, and you get your diagnosis very quickly. Better staff experience, better patient experience.
And this is so on point, Jeff, I was going to say, because again, when you look at this report, it's talking about nearly 80% of healthcare leaders are concerned about the possibility of data bias in AI applications. And so it's really refreshing to hear the way that Philips is thinking about this and taking a really transparent and really responsible attitude, which of course you would expect from an amazing company like Philips. What about the elephant in the room, interoperability? You know, how is Philips thinking about data integration and just, you know, making that a seamless process? Because we have all this technology being brought to the patients, but then clearly it's about how do we communicate and share that information?
Brilliant, brilliant. Yeah, so to enable a lot of those things, and if I went past the stack I just talked about to how do I make more predictive analytics and social determinants of health, sort of real AI-based analytics on population health, to do that, you really need good record quality, right? So while we're working on automating things like a nurse or a doctor speaking their notes into a generative AI app that actually pre-formats and allows us to populate the health record, it also just has to be interoperable. So we've adopted a position of complete interoperability to work into patient records. Our software layer, our platform that we're driving, we can collect over 1,200 different devices, data from different devices, and synthesize that or harmonize it into a health record. So part of our strategy is to innovate on interoperability. I'll go back to my example on that ROC, that command center for radiology. 80% of our scans are on someone else's MRI because I actually don't, I want to have that end to end, but I also understand all hospitals typically have a conglomeration of OEM products. And so our job is to make sure everything we do is interoperable and agnostic to the device that you're collecting, because the intelligence is in the data synthesis and how it interoperates with the health record.
And I think this is so important for any innovator at any stage to understand, because clearly in terms of the workflow and when you're in a procedural place delivering healthcare, there's a number of other technologies and other systems that are being utilized. And so that interoperability is so key to it. I'm wondering if there's any particular examples. I know you alluded to before, but when you're thinking about AI, you're clearly talking about a collaborative approach, working with partners. Are any examples that jump to mind?
Well, but yeah, how long do we have? I'll talk about one because I was just there a little while ago, and NYU Langone, probably one of the most digitally savvy hospital systems that I've worked with. And why do I say that? They are thinking about minutes of a nurse's hour, of how do I streamline that time of a nurse to make sure she has the most time. So why I say that is because we have a clinical insights and analytics application that sits over top of their health record, right? So we're controlling 1,000 devices in that hospital that is synthesizing that information into the health record and then presenting it back to the nurses with actionable decision support. So if I'm a nurse there, I don't have to be at the station. I can be doing anything I need to do. If I have a patient assigned to me, it tells me, this is at NYU Langone, it tells me I have an alarm going. I don't have to have it going on in the room. I have it to the nurse. She can take it or pass it to the next nurse if she's got a higher priority. And she can pull up the whole monitoring, the whole telemetry right on her phone and look at the screen to say what is specifically the issue. And then she can choose to interact or call a cart or to go to the room or to pass it off. It's unbelievable that just the little things. If you save 10 minutes an hour for every single nurse in that health system, you're greatly improving the quality of care. But it starts with thinking about the nurse workflow. And because we're interoperable, it's not just the Philips devices that are monitoring. It's the anesthesiologist. It's the ventilator. It's every device that might be in that patient's room and that patient journey across the hospital that I can synthesize that tracking right on the phone too. It's really incredible.
No, Jeff, you make it sound so simple, which is awesome, right? But obviously, there's got to be some adoption challenges, right? So, obviously, teaching these clinicians and nurses really how to leverage the tech is everything, and you were kind of alluding to that earlier. So how is Philips kind of approaching the education side in making sure that these clinicians, feel comfortable and equipped?
So first of all, it's way more than just clinical adoption teams that everyone in the industry has clinical adoption teams. It's not just more of that. I want to draw back and say it actually starts at the top of the organizations. If our strategy and the hospital strategy are aligned, NYU Langone is probably a great example because they are so focused on nursing workflow and productivity inside the walls of a hospital or radiology workflow. They're so focused on it that we can come in. Their idea is they want a partner that's going to help them put it together. I need to come in and watch what they're doing and meet them in their workflow, right? So when we're designing the system, it's actually tied to how they operate. So the first thing for me in that is it's not just clinical adoption, it's true partnership so that we're simplifying it for them and they're inviting us in and our job is then to make sure the workflow matches how they work so that we're not driving massive change to the system. We want the system to work for the caretakers.
Well, this is really interesting because we're talking a lot about, the hospitals and the clinicians today there. But what about my buddy earlier that I was talking about? The guy that went off to college, got his master's in biology and said, you know what? I'm not doing it. I'm going in a different direction. And is there a focus on the education system and bringing your technologies into early education to really get these students, and these hopefully these folks that will soon be doctors one day, to get them, aware of what's going on and what's changing and evolving throughout the industry that they can actually look forward to and be excited about, knowing like, hey, this isn't going to be some brutal career experience. There's real innovation happening, that's going to help me in my job and treat more patients better, more efficiently, and still, really enjoy the work that they're doing. Are you doing anything in early education, I guess?
I'll answer it slightly different than early education, but if you think about where the best innovation, or a lot of the great innovation, I should say, is happening in health systems, the Stanfords of the world, the NYU, Langones, the Mayo, I could name 30, but the innovation is happening at academic teaching where people are entering schools. And so as systems are trying to recruit from high school and bring technical jobs in and get that training, we're partnering with them. This is why I say partnerships matter, because for there, it's about us enabling them to draw talent because of the technology we bring, and them being able to sort of embed that into their curriculum and how they train people for the next generation, because we need to train future technologists, right? We're not just training clinicians, we're also training clinicians that have to be technologists. And so it's really embedding it with those deep partnerships with the innovation centers around academics.
Yeah, as much as we have this technology now, we still need to embed this for future opportunities. And I think this education will hopefully reap the benefits in the longer term. It makes me do wonder, though, about your sort of milestones. So you have this report and, you gain so much insight. What does it look like now for Philips over the next, say, 6 to 18 months? Like, what do you do with that information?
I told you about our mission, right? So we want to fish in waters that are biting, right? So I mean, there are systems that are in trauma, and there's systems that are in trauma, but also understand they need to lean toward the future. And so we're spending a lot of time and energy with those systems to try to, I would say, proof out technology at scale. That's I think where you hit the tipping point is when you take what you have, and I always say I'm a simple guy. Take what's on the truck and work with it, paint a vision, but work with what's on the truck. And there's a lot of technologies available for willing partners to bring us in. But I think healthcare, again, I'm going to restate it. For us, it's a human right. And so we're trying to break paradigms, not just with health tech providers or health providers. We also are trying to do it with advocacy groups and with regulators and government agencies like the CMS, in terms of how we make sure that we can infuse coding and reimbursement into the process, so payments can be more available for things like remote patient monitoring, which today is what is covered, what's not. It's a slow process. So we're also expanding our scope, not just to help hospitals engage with leading technology in their innovation, but also with sort of the political body that is going to help fund or advance some of the mass adoption of that, because we have the right payment schemes, which ultimately will save money and lives. But we've got to proof that out. So we work in both directions.
And Kyle, I think that's ultimately we're all facing in the same direction. It's all about improving lives. And again, that mission statement, I think even on the report itself, better care for more people. What about the actual technology that's now in place? Can you maybe say a little bit about how that's helping improve lives today?
Well, so we have, like I said, we do a lot of work with the VA, and so one of the areas with the Veterans Administration with remote patient monitoring, right? A lot of veterans are aging. Again, this is a beautiful microcosm of the broader socioeconomic realities of the world, right? In the Veterans Administration, so we're sending folks home with tracking arrhythmias, so we can be predictive analysts. We've actually been able to reduce hospital visits by close to 30%. During a study with the VA, to be able to show that we can actually keep people out of a hospital, and a significant decrease in days in a hospital by being able to send them home after an event with monitoring technology with no events. So our ability to monitor people home to hospital, we start with closed ecosystems, and then we kind of work how do you bring it to scale, but significant. The other one I would say, and you guys are familiar with this, perinatal partners of New Mexico. I think Jennifer may have talked about this, right? Where we're deploying OBGYN ultrasound scans at scale across the state from essentially a command center of obstetricians that are able to do this in remote community clinics all across New Mexico that have a significant improvement in both maternal and or decrease in maternal and infant mortality, perinatal mortality, as a result of having better early diagnostic and earlier intervention during scans. So we've got some published papers. I'm happy to send that as a link to you on those outcomes.
Amazing.
Jeff, this is like so much bigger than Philips right now, and you just do such a great job, making it crystal clear for the industry and really everyone throughout the world. And, you're working with all of these healthcare leaders at these various, hospitals. But you might not be working with everyone, and some hospitals are going to be further along than others. And really, how do we unify all of the hospitals? And what maybe might be 1, 2, 3 tips that you might have for some healthcare leaders, that might feel behind in this space, or might feel like, geez, like, how do we approach this? What do we do? Obviously, it's intense. This can be daunting. So what kind of advice and tips would you have for them?
Yeah, wow, the first thing I would always say is pick up the phone, right? I mean, I'm saying that to be really simple about it, but fundamentally, there are hospitals that we visited. They're very small systems that once they understand what's available, they are wickedly fast to adopt it, right? And they want to move fast because they see the value. And so sometimes those are our best adopters, and they just don't know about it. So uh, when I talk about true partnerships, we have to go deep on innovation and co-collaboration, and you can only do that so many times. But we do want everyone to hear your podcast. We want them to listen to this and say, what is possible? Hey, let me pick up the phone and call Philips and say, what are you thinking? It is bigger than Philips. Our mission in life is better care for more people. We can align on that mission, and then we go close to what those communities serve. So, for example, I'll leave you this one thought. It's a very poignant example of this. Roswell Cancer Institute in Buffalo, New York. They have one of the highest mortality rates for lung cancer of middle-aged Black men with comorbidities that have smoked in the whole country, and less than 5% of people that are eligible in that category are actually going to get scans or diagnostic scans or checkups to make sure their lungs are clear. So it's a very late stage diagnosed cancer, your high mortality rate. So very low scans, very high mortality rate. They're like, we got to fix this. Phillips, what can you do? Well, we hadn't done this before, but we figured out how to put a low dose CT on a truck, on a flatbed truck, and encase it and make it basically a mobile scanning lab. We took it into the community where these people a lot of them don't have cars. They don't get around much. They're not going to go to a hospital because they're frightened of hospitals. So we put it in the community. We didn't get much uptake. Lesson learned. Someone with Roswell was close to some of the pastors in the local churches. So we moved it to church parking lots and talked to the pastors about what we're trying to do. And all of a sudden we filled up. And now we have a community that would never have a scan, that is a high likelihood for lung cancer diagnosis or death. And now they're coming and getting early warning scans, early detection scans, and we're improving quality of care. That was completely random. Then the state of New York and the city of Buffalo kind of chipped in. We said, what else could we do? Firefighters, same challenge, high mortality rate for lung cancer. Why can't we just expand what we already done to fire? So now we put it at fire stations, and we've improved. So once you get the technology as small as it is, the sky's the limit, because now you can scale it to other applications or other demographics. And that's the beauty of what we're doing. So local, pick up the phone, call your partner, and start solving a problem together and get a win.
Jeff, unbelievably inspiring, man. Fantastic. So, how do folks here in the audience get their hands on the Future Health Index report? Because obviously there's a lot of, I think, key data points that we discussed today that go into a lot more detail. So where do they get their hands on a copy of that?
Well, I'm assuming if they're listening to your amazing podcast that they have access to the internet. And so usa.philips1l.com. Go to our news site, our news backslash, and you'll find it there. And it is alarming. It's about a 20-page read, but it is alarming how significant the trends are and how real the opportunities are. Then it becomes a matter of getting started, right? Get started on one thing that is a major problem. Bring a partner in. We're certainly glad to take your call.
Yeah, perfect. Well, we'll be sure to include the links to make it nice and easy for the listeners to access the report, no doubt. So,
yeah, definitely recommend checking it out. We talk about in every episode about being informed and inspired, and 100% this is happening today. And that report is just packed with insights. And I think it talks exactly to what Philip's approach is. You're listening to the healthcare professionals, and that story you just told, you're listening to the community, and then you're acting on it, and you're truly making a difference. And so, that little statement, better care for more people, is going to happen with this approach. So, Jeff, this has been fantastic. Can't thank you enough for coming on the show today and sharing all about what Philips is doing and your mission.
Well, I appreciate you guys having us on. We're passionate about what we're doing, and I find that same passion in you, and hopefully your listeners will be inspired to take that step.
Awesome. Well, ladies and gentlemen, another huge thank you to Jeff DiLullo, CEO of Philips North America. And thank you for tuning in for another episode of the MedTech Impact Podcast. I'm Kyle Cruz.
And I'm Richard Beaglejohn. Until next time, keep innovating.